I think this is a very important topic because a lot of underestimation and a lot of underdiagnosis happens with sleep apnea. So this is a very important link, and we'll try to understand the profound connection between the two often overlooked health challenges. And let's begin with the quiz. I think feel free to answer because that's how the vacuum will be created and a lot of practical points will be taken in. The presentation is, I've tried to keep it short. So let's begin with, anybody can answer. What percentage of patients with resistant hypertension are estimated to have an underlying OSA? Can anybody guess? Just wild guesses. Anything, whatever. 50 to 80, fantastic. So I think sir has answered it right. The incidence is enormous. Like that means every resistant hypertension, you need to check for sleep apnea. So this is something which all of us should remember that why it is important. Now, anybody knows the mechanism which explains how OSA contributes to resistant hypertension? Is it increased vagal tone during sleep, intermittent hypoxia causing sympathetic overactivity, reduced salt sensitivity, increased renal clearance of sodium? Yeah, so very obvious, hypoxia triggers the events of sympathetic overactivity. We'll look into it. Now, are you aware about the various scores which can actually evaluate and can help you in day-to-day clinical practice? So which of the following is the strongest predictor of OSA in resistant hypertension? Neck circumference more than 40. Anybody aware about Malampatti score? Morning headaches, BMI high, but neck circumference more than 40 is an important risk marker and predictor of OSA. Which treatment lowers BP in patients with OSA and resistant hypertension? So quite obvious, CPAP therapy. So not only diagnosis, but taking the right treatment is absolutely important. Otherwise, what is the point in diagnosis when we are not going to give the treatment? So a practical question, 55-year-old male, 4 hypertensive, heavy snoring, daytime sleepiness. What is the next step? Sleep study, increase antihypertensive dose, add spironolactone, start. Correct. So we are in a sleep session. So obviously sleep study. Before continuously escalating the medication, it is very important to diagnose, and we have seen that 50 to 80% will have obstructive sleep apnea in various studies. So it is important that we diagnose, refer these patients. Patients are pretty reluctant. They say we don't snore, I am sleeping well. All those questions are there in their mind, and sometimes they will not realize that once they do it and diagnose and treat, the BP starts becoming normal significantly. Now, which is not a consequence of untreated OSA. Somebody has been diagnosed with OSA. Now, which is not the consequence of untreated OSA. Resistant hypertension, we all know. Type 2 diabetes, atrial fibrillation, low risk of stroke. D, because all other are risk factors for untreated OSA. So if somebody has got sleep apnea, they have increased risk of resistant hypertension, this is a diabetes conference, and we all know that it also leads to insulin resistance, metabolic syndrome. The risk of atrial fibrillation also increases. Somebody who comes to you with atrial fibrillation, not getting control on amiodarone, not getting control on medication, you will see if their other criteria are fitting. Get the sleep study done, get it treated, and you will see that the atrial fibrillation burden also starts reducing. So one entity, but I think a significant impact on the cardiovascular disease. Every single OPD, I must be referring a lot of patients for sleep study because these are all related to the cardiovascular disease. So let's look into what is sleep apnea. Sleep apnea is a common yet frequently underdiagnosed sleep disorder characterized by recurrent collapse of the upper airway during sleep. This leads to repeated episodes of apnea or hypopnea, intermittent hypoxia, significant sleep fragmentation, and chronic sympathetic nervous system activation. Anybody knows the definition of resistant hypertension? And how many people must be having resistant hypertension? So there are two definitions, and then we have the resistance. So the first definition is blood pressure remains above target. So normal target is 130/18, most of our patients in our profile, despite concurrent use of 3 or more antihypertensive medications from different classes, including a diuretic. So diuretic has to be included. Or somebody is on 4 or more medications to get it less than 130/80. Also comes under resistant hypertension. So he's on beta blocker, ACE inhibitor, on diuretic, on alpha blockers, all 4 or 5 drugs, and then under control. Then also is a resistant hypertension. Resistant hypertension is about 12 to 15% of hypertensive patient, and is associated with significantly increased risk of cardiovascular events. Now, the OSA resistant hypertension connection, prevalence and risk, we have seen that there is a high co-occurrence. So therefore, we should evaluate in all the patients. Increased risk of developing hypertension. Somebody who has got OSA will have high chances of about 1.5 to 3 times to develop hypertension. And more the severe OSA, more frequently they will have issues, and they exhibit nighttime and 24-hour blood pressure readings which may be fluctuating, indicating a direct correlation. And we looked at the predictive factors like large neck circumference, age over 50, habitual snoring. Have you heard about the stop bang criteria? Stop bang. It's a clinical criteria to diagnose sleep apnea or predict sleep apnea. We'll discuss about it. Now, looking at the pathophysiology, how OSA drives resistant hypertension, we looked at various things. Sympathetic overactivation, because intermittent hypoxia leads to chronic activation of sympathetic nervous system, resulting in sustained vasoconstriction and elevated BP. So sympathetic overactivity will always cause vasoconstriction, will cause rise in blood pressure. Nocturnal BP surges. See, nocturnal BP surges and nocturnal non-dippers will have higher chances of cardiovascular disease. And how do you identify all these patients? Nocturnal non-dippers or nocturnal rise in blood pressure. How can you identify? Ambulatory blood pressure, perfect. So somebody who's got BP which is controlled when he comes to your office, but when you do the echo, there is LVH. When you do UACR, there is proteinuria. These are the patients who are having end organ damage, and therefore we need evaluation for these patients. They might be having nocturnal BP surges, and as doctor said that our ABPM is a good way. RAS activation, endothelial dysfunction, and endothelial dysfunction is a precursor of so many diseases, including impaired glucose tolerance and all other. It's a precursor of atherosclerosis. Now, clinical challenges in diagnosis is most important is underestimation. So routine office blood pressure measurements often fail to capture the true severity of hypertension in OSA patients, especially during the crucial nocturnal period. And therefore, ABPM is essential whenever you have an obese patient with end organ damage, and then you want to find out whether they are nocturnal non-dippers. See, in night the BP should dip down, and if it is not dipping, it's not good. It's a nocturnal hypertension. Although also there is a phenomenon of early morning surge of hypertension. This can only be identified when you are wearing a ABPM. So if you have, I'm giving you these clues because in your clinical practice, if you find something like this, you should utilize this. And overlooked symptoms, when you ask them how is their sleep, they will say I sleep very well. Actually वो बोलते हैं ना घोड़े बेच के सो रहे हैं, because they are snoring. Snoring people are actually called as घोड़े बेच के सो रहे हैं, because they think that they are disconnected to the world and they are into deep sleep, but actually hypoxia, fragmented sleep, all these things are there, and they present with then suddenly issues. Now, what are the treatment strategies? CPAP, we all know, and the sleep specialists have to, when we diagnose it, I always refer it to the sleep specialist, who then go into various ways, various therapies which are available. There are sometimes, anatomical recovery which has to be done, reconstruction, so ENT, sleep specialist, all these people are needed to correct depending upon what the outcome has come. Targeted antihypertensive medication, so usually aldosterone antagonist like spironolactone works quite well in patients with resistant hypertension, and we should have a low threshold of starting this medication in case the blood pressure is not getting controlled. So there are 3-4 medication which is already on, patient is on CPAP therapy, you have put it, but initially if you look at most of our patients who are put on CPAP therapy, they are uncomfortable. They will not utilize CPAP therapy for as long as they would require. At least 4 hours of nighttime therapy is needed, CPAP therapy, to get its maximum benefit. And I think this is part of all lifestyle related disease management, which is comprehensive BP management, where you utilize a holistic approach to blood pressure control, including weight loss, dietary adjustment, smoking cessation, alcohol moderation. All of these are going to help in getting a better patient outcome. Now, these are emerging insights and future directions for resistant hypertension in sleep apnea. So phenotyping OSA mechanisms, as I was discussing, finding out the anatomical obstruction versus non-anatomical traits like ventral control instability, can personalize treatment strategies for hypertension, moving beyond a one-size-fits-all approach. So I think a proper sleep specialist and a sleep consultation is needed once we have diagnosed with sleep apnea. There are novel pharmacotherapy for resistant hypertension which are now being utilized, and ARNI has been tried ARNI, we all know, is an important medication for heart failure. It's one of the 4 pillars of heart failure, ARNI. And this has been also now being studied in resistant hypertension. Similarly, SGLT2 inhibitors have known to break that resistant hypertension cycle. So these are all novel things, GLP-1 receptor antagonist. All these are, I think, being discussed in this great conference. And enhanced screening guidelines. So pick up the cases, routine screening for OSA in hypertensive population, especially those with resistant hypertension, to facilitate early diagnosis and intervention becomes absolutely important. So just to conclude, and then I will quickly revise what I have said because I was fast. This topic is simple, but we are more unaware about the impact, more unaware, and patient resistance is also there. Sometimes we also in our busy practice, we forget to discuss about the sleep related issues. So integrating OSA management in resistant hypertension care, modifiable contributor OSA is significant and modifiable factor contributing to resistant and overall cardiovascular risk. In fact, heart failure with preserved ejection fraction and heart failure with reduced ejection fraction are also associated with sleep apnea. Somebody who comes with dilated cardiomyopathy or even with preserved ejection fraction, you go into their sleep history, and if you find that they could be a sleep apnea patient, sometimes they will say everything is okay, but you do their sleep study and you will find that they have a risk factor of sleep apnea which is present, and if you treat them, they would have very good impact. So I had a lady who was doing well, little obese, 75-year-old, came with biventricular heart failure. I did a sleep study. This is a recent case, so I just remember. And when we started her on sleep apnea treatment, her LV function and RV function both have improved, and she is doing very well. So these are certain things we start wondering, and we write them off that nothing can be done because now EF has gone down to 25-30%. Early intervention, prompt diagnosis, and a combined therapeutic approach, including CPAP and tailored antihypertensive medications, are crucial for improving patient outcomes. Multidisciplinary care, effective management necessitates collaboration among sleep specialists, cardiologists, and primary care providers. I think we all have to suspect, get the investigations done, and then refer to a person who is taking care of the sleep apnea. And prioritizing patient education and adherence to prescribed therapies of paramount importance in optimizing blood pressure control and preventing long-term complications. So I think this is all about sleep apnea and resistant hypertension, but sleep apnea is associated with a lot of other, as I was discussing about the heart failure, about the insulin resistance and all. This is just the quick revision. More than 3 drugs, including a diuretic or controlled on 4 drugs, 10-15% prevalence, 50-80% associated and strong independent risk factor for poor BP control. OSA often remains underdiagnosed. We discussed about the pathophysiologies. These are clinical clues. Loud snoring, witnessed apneas, morning headaches, daytime sleepiness. Epworth score is very easy. You can just go on the Google, put it on your chart, or whenever the patients are waiting in the waiting area, you can ask them to rate. It's very easy. It's available. Neck circumference more than 40 and patients not getting controlled. This was the stop bank questionnaire which I was saying, very easy to remember. S stands for snoring, tiredness, observed apneas, because the wife or the spouse or the partner will say that sometimes inka sote I see that the saans ruk jata hai, and then he or she goes back to sleep again. So these are observed apnea and high blood pressure. So stop, and BMI more than 35, age more than 50, neck more than 40 centimeter, and gender male. This is a stop bank questionnaire, quick and easy screening in the clinic. And if you find them, then you can obviously advise these patients about the sleep apnea. They also understand. People today in this era want to have scoring for everything, and that gives them the objectivity as well as, when you ask them to mark, they will see and they will be more this thing. So gold standard is polysomnography, alternative home screening, and Epworth sleep scale. This is CPAP therapy improves nighttime BP and dipping pattern, better outcomes if adherence more than 4 hours per night. We discussed about the medical therapy. Integrated management is of paramount importance. And whenever you have a resistant hypertension, look into all these 4 things, rule out OSA by using various criteria. So every resistant hypertension patient should be screened for OSA, and treating OSA improves BP, reduces pill burden, and lowers CV risk. Thank you very much.